Um, Melissa has asked me to remind you all to please fill out the grossing survey regarding how long it takes you to gross things, et cetera. So we're trying to sort of come up with a better, or at least a clear way to assign specimens kind of by time rather than necessarily by just, you know, your service. I mean, your service is certainly still important, but other institutions have kind of designated time equivalents for various big routine, et cetera, specimens. So we were hoping to generate a similar thing to kind of make it fairer for everybody. So if you guys would mind doing that, that would be great. Secondly, you know, this ENT block, because a lot of my lectures are already recorded on the YouTube channel, which hopefully you see here and you have the link for in the highlights of the week. The sessions I'm going to be giving this block are going to be more unknown focused. I'll add in a few didactic slides here and there, but please feel free to watch all these others. Please go on to the M Drive, because even if I don't have recorded lectures on something, I do have PowerPoints on everything. So in the M Drive are all of my PowerPoints, PDFs on all of my lectures. If you need help finding out how to get there, ask me or the chiefs. And then, so let me get rid of this YouTube thing. The other thing I wanted to say was we now pay for University of Chicago version of Path Presenter, where we pay for storage, because any of you who've used Path Presenter and have tried to upload your own slides may have come into storage issues where they cap it now. So if you have any need for Path Presenter for research, for your other presentations or whatever, let me know. I'll set you up an account. The other thing that I want to mention, which you hopefully saw the email from me about before, was regarding quizzes. So they do have, excuse me, a quiz and an assessment function. I have created a small, very brief 5-question quiz for today's material that some of you have looked at. So thank you. And I will ask for your feedback on that when you are ready to give it to me. But in the future, we may be using this for your 6-month Surge Path exams, because it's integrated, the slide, the question, it's all integrated. So if you see an email from UChicago Path Presenter asking you to sign up for an account, please do so. You just basically put your name in, put a password in, and then you have access to the UChicago account as a trainee. So just be aware of that. If any of you would like to take the brief quiz following this lecture, again, just let me know and I can set you up. And thanks again for those who have already agreed to doing it. So does anybody have any other questions, comments, thoughts before we begin?
Good to go.
Okay, so let's get full screen. Excellent. So the first, I've kind of separated into neck, ear, and kind of sinonasal, because those are some of the spots that we do see. We see a variety of diseases, as you know, in the head and neck. So this is going to be the, non-salivary, non-squamous, non-thyroid. This is kind of miscellany, everything else. So if you guys don't pipe up, we're going to call on you. So just beware. All right. So let's at least start with slide 1, which is a neck mass. So can anyone, at least maybe one of the juniors, at least just describe what you see and what we might be looking at as a neck mass? I see Reham down there. Is she available to describe?
Yes, sure.
All right.
So here I'm seeing from lower power, it's like homogeneous eosinophil material, like well-defined or well circumscribed, and is filled with eosinophil material. And here I could see, like, could I call them keratin strands or, yeah.
Certainly.
And in the middle, it's maybe ghost cells or, yeah. And it's here. Yeah, you already mark it.
Uh-huh.
Yes, here. It helped me a lot when I reviewed the slides. So here we have, we call this transitional cells. If the diagnosis is pilometricoma, means that's what I saw.
Okay.
So, and I saw calcification as well.
Mm-hmm.
At the periphery, yeah, here.
Mm-hmm.
So at the periphery, it's adipose tissue. I saw skeletal muscles. I believe this is lymph node or here.
Okay.
And the lymph node contains this material as well, here.
Yeah.
Yes.
Mm-hmm. So, okay, so you think this is a pilomatrixoma?
This is what I saw. Yeah.
Okay. In what age group do pilomatrixomas generally occur?
In children, I believe.
Okay.
And
Okay.
it could be multiple if there is a syndrome.
Okay. And so if I were to tell you that this is not an adult, this is a 58-year-old male, would you change your concept? Maybe a senior can pipe in as well with some additional comments. And I know this is a challenging one because I haven't given you the whole story, but sometimes you don't get the whole story.
Okay. So if it's not pilometricoma, let's think about differential diagnosis then. It's something related to skin. I believe skin.
What
Could
makes
it
you
be?
think that? Do you see skin on this slide?
No, no, no. So I mean, could
But
it
you
be
do see this, which you already mentioned, which is
lymph node?
lymph node.
Yeah.
Okay, and you see some of this material potentially in the lymph node.
Yes.
Right.
Yes.
But do you think this lymph node is related at all to this larger nodule?
It should be though. If I see the material inside it, so they should be related.
Okay, so
but I'm seeing this keratinocyte or keratin.
right.
So could it be any type of keratinocyst, for example, or?
It certainly could be. Does anyone who's seen these types of specimens before want to comment on some other options?
Pilar cyst, I'm thinking about. I need help.
Yes. Seniors.
Could it be an epidermal inclusion cyst that the lining was denuded? I actually was kind of struggling with this
Do
one.
we have any kind of mucinous material sometimes, or?
So I guess thinking in the neck, I mean, it looks a little bit cystic, little degenerated, thyroglossal duct cyst, which happens more in the children, especially enlarged when they get infected, branchial cleft cysts. That's a little bit what I was thinking, especially with, I know we talked about like lymphoid, or well, I guess here we have like a little bit of granulation tissue, some calcifications. Wasn't entirely sure if it was a lymph node, if it was just a lymphoid aggregate, because it wasn't really seeing a great capsule. So, and you know, with the branchial cleft cyst, you can also often have association with lymphoid aggregates. And the material within that lymphoid aggregate, it also wasn't a little bit clear if it was part of the lesion or if it was maybe a little bit of carryover, because there was also some ink. So I don't know. And it looked like the outside had been inked. So could be part, could be carryover.
Okay. All right. So when you're dealing with a neck lesion, especially in an adult, especially in a middle-aged man, you always want to know what their history was. And if you don't have a history, you always want to assume something is cancer until proven otherwise. So who knows what the answer is in this case, and it's tricky.
It's
Yeah,
cancer?
I was wondering if this guy had had radiation before.
Yes. So this.
Okay, great. So I thought that was viable tumor in the middle, actually, between your green dots.
So
and
this.
Maybe.
Continue.
Okay, so I thought this could be maybe some viable tumor. I thought he maybe had like a history of squamous cell carcinoma that he had gotten radiation for, because a lot of that like pink stuff in there looks like ghost cells, like Riham said. That's exactly right. I see a lot of dystrophic calcifications. And around the edges, I think I maybe see some like residual sort of like lymphoid parenchyma that's kind of trying to come back. So what I thought this was a node that had been basically entirely taken over by cancer and then subsequently irradiated.
Check. So that's correct. So in most cases, we know the patient's history, right? And we can say, okay, they've had metastatic squamous cell carcinoma in the neck. They've undergone chemoradiation. There is a persistently enlarged lymph node and they take it out. Sometimes you get these cases from the outside, right? Where you're like neck dissection. And this is the characteristic appearance of treated squamous cell carcinoma in a lymph node, okay? So you have a clue that you're in a lymph node zone because you have a lymph node here. Remember that when carcinomas efface lymph nodes, whether they are viable, not viable, whatever, you don't always have a rim of lymphoid tissue, right? Because if that node effaces, if that cancer completely effaces the node, or if you are in a section of the node where you don't see any residual tissue, look for clues on the outside and here you find it. And so basically there's nothing at the periphery to tell you that this is lined by any type of epithelium. So you guys were talking about neck cysts, pilomatrixomas, branchial cleft cysts, et cetera. Well, at the edge of this fibrous, capsule, there's no separate epithelial lining to suggest that this may have been lined by any kind of epithelium. All you see is this grungy keratin debris with, in this case, some nucleated squamous cells, which were, pointed out for you between the dots. And so these are challenging because they're treated tumors. They often manifest with various levels of treatment effect. And this is one where I would say there's kind of keratin debris. And the question is, are these cells with nuclei, are these viable tumor? So let's look at the next one for comparison, and then we'll talk about the differences. So I'm just going to jump right to it here because I've made you struggle enough with the first one. So in this case, we have the same issue where there's lymph nodes at the periphery. So you're probably in a lymph node rich zone, right? So if we think about what's a soft tissue deposit, what's a cyst, what's not a cyst, what's a lymph node, what's not a lymph node, chances are if you're in a lymph node rich zone, you're probably in a lymph node because that's how lesions get to these areas, right? They travel through the lymphatics, they deposit there. Sometimes they efface them, sometimes they blow through them, right? But generally they usually started in a lymph node. Okay, and we don't see skin, right? So we're not in the dermis, we're not in a skin associated structure.
Can
What
I
you see here,
can I take a whack at this one?
yeah.
Yeah, sure. So we have is a very, very fibrotic, just dense sclerotic area with some siderophages. But adjacent to and kind of between the siderophages, I noticed that there's sort of an infiltrate that's plasmacytoid. And initially when I look at a lymph node that's completely been what looks like might have been a lymph node that's been completely sclerosed over, I would think about like a nodular sclerosing Hodgkin's. This does not have that appearance, but a dense plasma cell infiltrate in a sclerosed and insulin that's this densely sclerosed. I was actually thinking about IgG4 mediated disease.
Okay, so something with a dense collagenous sclerosis with lymphoplasmacytic infiltrate certainly could remind you of an IgG4 related sclerosing disease. Usually those don't have quite such hemosiderin because they don't, they're primary. So they don't, to me, hemosiderin is an evidence of some kind of reaction, some kind of hemorrhage, some kind of tissue damage. Usually IgG4 don't have quite as much hemosiderin, but okay. And I'm going to show you the one focus that I think is hopefully going to maybe raise another.
Was it that kind
these little epithelioid cells?
Yeah.
All right, with nucleoli. Here's one with some cytoplasm. Here's one with a large nucleolus. So the history in this patient is exactly the same. All right, so this is a person who's had squamous cell carcinoma of the neck, status post-treatment. The difference is this one has what I would call nucleated keratin debris and is potentially non-viable. We could debate about that though. This one has epithelioid cells where nuclear detail, including nucleoli, and chromatin characteristics are visible. Therefore, I would consider this viable tumor. So first of all, always be cautious with these treated carcinomas in the neck, because as I said, they can have a various manifestation of viability. We have done studies on these ones with keratin debris showing that they basically don't have any Ki67 staining. So we think that they're post-mitotic. So we think that this is not actually viable tumor. So if they have wrinkled nuclei, very dense keratin, where you can't actually make out nuclear detail, we expect that to be non-viable. And we call this essentially nearly treated tumor. However, in a case like this, where you see a focus of epithelioid cells and you see chromatin characteristics, you see nuclear detail, I would call this viable tumor. And so you could use things like Ki67 to tell you if any of these cells are mitotically active. You could even use a keratin or a P63 to tell you that they're squamous cells, right? But you can identify that they're epithelial cells, and you have to identify whether you think they're viable or not, right? So I want you guys to burn this appearance into your brain of treated lymph node and make an educated distinction of whether you think these are viable or non-viable. Okay. Questions, comments? I know that was a tough one at the start. Okay. The third one is similar but different. And we've got a lymph node, right, with some kind of pink material in the center, but someone can maybe describe what is a little bit different about this case. And the history is not the same in this one. So don't worry about squamous for this one.
So, I mean, I can try. So it seems like we have like two lymph nodes, or at least two sections of lymphoid tissue.
Yep.
That has a rim of viable lymphocytes that is making me think that it's just like we are in the lymph node. But then the center is like very pink, but has like some myxoid appearance. I would say like on the lower power, it does give like a blue hue to it. And then it's like I would say like there's no dispersed nucleated cells to make out that if it is if there is any viability of cells present.
Yeah, it's all very kind of grungy, right? There's not like,
yeah. So I think at this point, if we have like some sort of history of the patient, because like I feel like this entire lymph node is either infarcted or necrosed, with no viability of if there was any positive, and in these ghost cells also doesn't give any clue that what I was probably like looking for any kind of malignancy in that, or like, no, we don't have any keratin. So yeah, when you said that it doesn't have the same history, I would definitely go with it. But I would also, add, somebody mentioned infection. Maybe if there's like so much necrosis, we can throw a little bit of the GMS to see if there was a history. Yeah, I think, the necrotizing granuloma, of tuberculosis, or any other infection that causes necrosis. We can think about I think we can think about infectious causes.
Yeah, so great. So this node was taken out for PTC. And so in the background of, papillary thyroid carcinoma and some of the other nodes, we see this. And so I'm pointing out this peripheral area to you here, which is at the edge of this grungy debris, right? And so what are these cells at the edge of the grungy debris? Some of you have already pointed this out: granuloma, infection, necrotizing granuloma. Exactly. So always look at the edge, right, of the necrotic area to see what's there. And in this case, we see these plump cells with wrinkled kind of coffee bean groove nuclei, with foamy cytoplasm without well-defined cell borders, right? So one of the things I always tell you guys when we're trying to look for carcinoma in lymph nodes versus histiocytes, always use the presence of cell borders that are discrete as an indication that you're dealing with epithelial cells rather than epithelioid histiocytes. Okay, so here we have epithelioid histiocytes with necrosis in the middle. So yes, these are necrotizing granulomas. And so you want serology, you want TB, you want AFB. So of course you're going to do AFB and GMS on this. This is the kind of granuloma that implies that there might be infection when it has these large necrotizing centers. If you were to only see very small, well-formed granulomas like the one I'm pointing out to you here, then you may think about sarcoid. So sarcoid tends to have very small, very tight granulomas, but not these giant necrotizing zones, okay? So here's the GMS, and unfortunately the scan didn't turn out perfectly, but and I can show you guys the actual, but see these little tiny specks? I can't go any higher than this. These are the fungi, right? So these little specks are actually fungal organisms when you look at them under the regular scope. Sorry about the scan. So in this part of the country, when you see little yeast forms, what organism do we want to actually think most about?
Histoplasmosis.
Histo.
Exactly, histo. So yeah, so the histo serum antigen could be done, blasto, GMS. In this case, the little tiny small ones with wrinkling of some wrinkling of the outer edges is histo. Yes, so this is a histoplasma granuloma in a lymph node taken out for PTC, right? So sometimes we have multiple things going on in the same patient. Very rarely do we see TB, but we do. So you have to do both the GMS and the AFB. And fortunately or unfortunately, in this part of the country, mostly it's histoplasmosis. So much less morbid than TB, but always think about fungi when you see these large necrotizing granulomas, okay? And so just for comparison, right, we have a difference between necrosis and keratin debris, right? That is treated tumor, between the second case, which is really arguably not necrotic at all. It's more hyalinized, okay? But this is okay. This is the kind of later stage of treatment. And then we have necrosis with very grungy material that is not keratin at all, but in fact has bugs, all right? So those are the first three. The next one, you guys got any more questions on those? Okay, the next one is a lateral neck cyst in an adult.
Looks like virus patches.
Indeed, indeed. You have epithelium undermined by germinal centers. So whenever you're dealing with any kind of mass, any kind of cyst, right, in the neck of an adult.
So Melissa kind of already identified this entity earlier when she was describing the first one. So we have a cystic space with squamous epithelium with associated lymphoid aggregates, and so this looks very much like a bronchial cleft cyst. I don't know if there was anything else you wanted me to discuss about it.
No, I think that's great. So this was meant to be relatively straightforward, especially in comparison to the others, right? Where you actually do see an epithelial lining at the periphery, which will tell you that this is some kind of cyst. You have a stratified squamous lining that is bland, right? So the other thing I want you to burn into your thought process is whenever you see a squamous lined cyst in the neck of an adult with background lymphoid tissue, right? You could be dealing with a branchial cleft cyst, which is basically a benign lymphoepithelial cyst, right? So you should see squamous epithelium and lymphoid stroma. However, you just want to make sure you're not dealing with cystic metastatic squamous cell carcinoma that has been untreated, right? So you want to make sure that your squamous epithelium is pristine. There's no, anything that looks like carcinoma or carcinoma in situ in it. Mitotic activity is low. So anything that looks like theoretically malignant in the neck is basically metastatic squamous cell carcinoma. This is the epitome of benign bland. So this is what is acceptable for a branchial cleft cyst. Otherwise, always consider squamous cell carcinoma in adults. Any other questions or comments on this one? This was just such a perfect example of a branchial cleft cyst. I had to show it. All right, remember these develop from the pharyngeal pouch apparatuses. You could get branchial cleft cysts in the lateral neck. You can even get them occasionally within the thyroid. You can get them in the salivary kind of area. All right, next one is also a neck mass.
I can try to take a crack at this one. So it's
Okay.
well circumscribed. I'm not exactly sure where in the neck this is, but I mean, I felt like these cells looked, they look like, for me, like grouped in kind of nests almost, but I mean, they're pretty bland, like epithelioid-like cells, but I don't think they're actually epithelial. And the nuclei are, you know, pretty regular. Chromatin's pretty eosinophilic. I mean, I guess the first thought I had was like, is this a paraganglioma, like a carotid body one? I know that those can show up in the neck. You know, along the lines of like what we've been talking before, I don't think this is like a squamous cancer. I mean, I guess I'd be interested in endocrine markers, maybe an S100. And then there's this thing here, which is
this the same or different?
it looks like a sclerosed version of like the same thing, basically. Yeah, it's all the same cells, basically. Yeah.
Yeah, so great. So this, excellent. So one, this came to you labeled as a carotid body tumor. So when you see something that's labeled carotid body tumor, whether you have that history or not, that is essentially the colloquial name for a paraganglioma that is arising in the bifurcation of the carotid body at the carotid or ganglion or whatever. But the features that you want to look for paraganglioma, regardless of whether it comes to you labeled as that or not, right, are exactly those features of nested architecture, where you see these very nice thin vessels separating the nest, or the, you know, the Zellballen, right? You have abundant cytoplasm that in this case is a little more eosinophilic as opposed to amphiphilic. Amphiphilic meaning kind of purplish, right? But the cytoplasm should be abundant. It should be somewhat granular. And the nuclei should, at least in areas, have that characteristic stippled, kind of salty, peppery chromatin. In this case, we have occasional nucleoli, which is a little, you know, we don't always see nucleoli in paragangliomas, but in this case, we do. So look for the nested growth, look for the cytoplasmic granularity, look for these salt and peppery kind of chromatin, right? And so like you said, you're going to prove that this is what it is by doing synaptophysin chromogranin, some kind of neuroendocrine marker, which should be positive in the lesional cells, some kind of S100, which should be positive in the sustentacular cells surrounding those nests. And what I asked, we had a case, yes, it was Brooke. We had a case the other day, and I said, what immunostain do we always do, even if you can tell it's a paraganglioma, you don't need synapto, what immunostain do we do for every single paraganglioma or pheochromocytoma anywhere in the body always, and why? And I'm going to show it to you next.
Is this lymph node metastasis? Because at the periphery, we are able to see kind of germinal center. So the tumor, it's already metastasized to the lymph node?
No, I think this is just peritumoral inflammation.
I mean, Dr. Antich wants SDHB and ATRX, but I don't know if those are standard.
Why does she want those?
So there are some studies suggesting that loss of nuclear expression of SDHB and ATRX is associated with malignancy. And the problem with PHEOs in general is that there's no great criteria to tell you whether or not it's going to be malignant. And so people have been looking into other ways to characterize them as having a benign course or malignant course. And one of the suggestions has been SDHB and ATRX.
Mm-hmm. Brilliant. So not only Dr. Antich, but also Dr. Cipriani wants SDH. We don't do ATRX because I think in the head and neck that's less relevant, but I'm going to look into it. But definitely SDH. So I'm going to say two things. One is there's a little bit of unusual morphology here, which was pointed out earlier by Heather, right? Where there's some sclerosis. There's some sclerosing growth pattern with this weird almost infiltration out into the soft tissue, and you start to see surrounding of these vessels. And yet this is all essentially meaningless for behaviors of paragangliomas and you know, for that matter, pheochromocytomas. So we see on one end of it, a well-circumscribed nodule. On the other end of it, this weird sclerosis that seems to be occupied by cells of very similar morphology. So I assume this is all still paraganglioma, and in fact it is. However, this is succinate dehydrogenase immunostain. So let's look at the, oops. Oh, there's no control on it. There's an internal control. All right, so succinate dehydrogenase, A, B, C, D, E, F, there's all these subunits of the succinate dehydrogenase complex. It is it a nuclear or a cytoplasmic stain based on the normal internal control?
Cytoplasmic.
Cytoplasmic. It's sort of granular and cytoplasmic because it's a cytoplasmic like cycle protein, what's the word I'm looking for? Like citric acid cycle, Krebs cycle, right? It's one of these. Remember back to biochemistry, succinate dehydrogenase, pyruvate, kinase. What's the word I'm looking for?
Lactic acid cycle?
Citric acid cycle or pyruvate. Oh my God, what's the one before that?
The Krebs cycle.
The Krebs cycle.
Yeah, whatever. Okay, exactly. All of that good stuff. The pyruvate metabolism. Okay, so you can tell I'm not a biochemist. All right, so it's a cytoplasmic protein present normally in all cells as a normal function. All right, here's that lymphoid rim that we saw earlier that we're going to say is probably not a true lymph node. Okay, when you have loss of any of the succinate dehydrogenase genes by mutation, that complex of A, B, C, D, E, whatever, can't form. So this is SDHB. But if you have a mutation in any of those subunits, the whole complex doesn't form. And so you don't have any significant immunostaining for B, right? So we're testing for B, we're staining for B, but it's going to detect mutations in any of the complexes. And so in this case, you can see how the sustentacular cells and the vessels around the nests still have granular cytoplasmic expression, but the tumor itself is extremely, extremely pale. So this extreme pallor of the neoplastic cells or complete loss of succinate dehydrogenase in the cytoplasm should alert the clinician to screen for germline succinate dehydrogenase mutation. Germline succinate dehydrogenase mutation is the only relevant predictive prognostic factor for these patients. So it's those with SDH mutation that are going to have the highest capacity for metastasis. Morphology is irrelevant. So as you said earlier, this is the only good clinical indicator of behavior in paragangliomas is succinate dehydrogenase mutation. Otherwise, morphology is useless. So interestingly, I don't remember what the outcome of germline testing in this patient was, but I do know that this patient had bilateral pheos in her carotid body. All right, so, or paragangliomas, sorry. So likely she probably does have a germline syndrome because she had bilateral paragangliomas of the carotid body. So always, always, always do SDH. I mean, I'm going to look at the ATRX for the head and neck because I don't do it. Other comments or questions?
Dr. Cipriani, I was wondering what it would look like if we found some sort of malignant case.
It would be metastatic to somewhere else.
Oh, somewhere else. So the extension just adjacent to it is not concerning, but if we found it somewhere else in the body, just incidentally?
Correct.
It would probably by symptoms. Okay.
Correct.
And
so the only way you're ever going to call a malignant pheo or a malignant para is when it's metastatic. It's either a pheo, para, or a metastatic one.
So, I mean, I have a question. So if we have germline mutation in SDH, that means it is malignant and hereditary, or no?
That means it has the highest risk of behaving in a metastatic fashion.
Okay, that means malignant paraganglioma if it metastasizes, right? Or okay, and we should check the family because it is hereditary here when we have the mutation.
Correct. So you check the patient with the tumor first, and then you check the family if the patient has the mutation.
Dr. Cipriani, I also read that this might be associated with the Carney triad with
Okay,
GIST and pulmonary hamartomas. Is that
okay.
something we should remember or not? I mean, you
Um,
don't think about it.
I don't think about it unless I see other features in the patient that make me want to put it all together, but that is it's so rare. But sure, for board's purposes or for a rare case, you could always remember that kind of stuff, but I'm not going to go like looking for, I mean, I'm not going to go searching the medical record in every paraganglioma for other things.
Just happens on the boards. Okay, thanks.
On the boards. Sometimes in real life, but more often on the boards. All right, other questions? Yeah, so you have paragangliomas and you have metastatic paragangliomas. Otherwise, you will never call it malignant unless you see it metastasizing, and you will do SDH only to predict eventual metastasis. It's more for patient counseling than for anything. So if you have loss of SDH, you're going to tell the patient they have a higher risk of having a germline mutation and they have a higher risk of behaving in a malignant fashion. Okay, that's all. All right, now we're moving into the ear. I put this here because I think most of you have seen these.
Everyone's read it in their Malawi textbook, I'm sure. I've actually never seen one like actually sent to us.
They do them every once in a while.
I
mean, it's like the larynx. You get it or you don't. Does a first year want to describe, or I can describe?
Who do we have on here? Let's call on someone who's junior who hasn't spoken yet. How about, I see Christine, I see Brooke, I see
Mia, Pari, Ryan.
Good, yeah, one of you guys. What is the predominant finding in this slide?
Keratin.
I think we see lots and lots of keratin or keratinaceous debris.
So we have a couple people saying keratin, and where's the keratin coming from?
We have this squamous kind of lining, and then it's like the keratin is just sort of being sloughed off all over the place.
Mm-hmm. And if you didn't know that you were in the ear, how would you be able to sort of gather that that's where you might be? Here's a hint.
Is this the lining of the inner ear, or wait, we have these sort of cuboidal looking cells?
Mm-hmm. So come out a little bit. The inner ear is your,
or sorry, the middle ear.
Yes. So this is middle ear mucosa, which we don't see very often because like you guys are saying, if we get so Perry, what is this diagnosis before we move on?
I think it's a cholesteatoma.
Right. So what is a cholesteatoma conceptually? Is it a tumor or is it a reactive process?
I think of it like as, this sort of gooey bundle of keratin with a reactive process going on in response to all of that junky keratin building up.
Right. So cholesteatoma is a reactive process, not a neoplasm. It happens in the middle ear. You can see here your beautiful kind of bland cuboidal middle ear mucosa. So this is very characteristic of middle ear mucosa. Often these patients have some history of chronic otitis media. So you may see inflammation of that middle ear mucosa. And cholesteatomas are this keratinaceous, squamous epithelium that exuberantly grows and builds up and can invade through the tympanic membrane into the ear and cause a lot of local morbidity, but won't ever, metastasize. It's sort of like almost like, I don't know. In concept, it's like an ameloblastoma of the jaws, right? Where it can be very locally expansive and locally aggressive, but it's not going to metastasize. And in fact, no one has ever proven a cholesteatoma to be a tumor either. It's thought to be a reaction to chronic otitis media with destruction of surrounding tissues. And so often all you see is just keratin debris. In this case, you see keratin debris. You see the beautiful squamous epithelium that's exuding the keratin debris. And you even see a little bit of that middle ear cuboidal mucosa. So this is a characteristic example of cholesteatoma. These giant cells, of course, are just reacting to the keratin debris. The other thing I wanted to point out was just because we don't see it very often, but the lining of the cholesteatoma is very similar to the lining of what structure of the ear?
Like the external ear?
So the
Canal,
external ear is squamous, but it's more skin, like thick skin with adnexal structures, etc. So the external
Sash.
auditory canal is still kind of skin. Mhm. What's the dividing line between the outer and the inner ear? I mean, the
Tympanic.
Like the tympanic
middle
membrane.
and the inner ear, right? The tympanic membrane, exactly. So the tympanic membrane is a very, very thin, highly keratinized squamous epithelium that looks essentially like what I'm pointing out to you here. So if you're in the external ear or the auditory canal, you should have ceruminous glands, you should have sweat, not sweat, but skin adnexal kind of structures. In the tympanic membrane, it's just that thin keratinized epithelium that basically histologically exactly resembles what you see in a cholesteatoma. The other evidence you have here, which I just noticed, which I do want to point out to you, is see here in this cuboidal epithelium of the middle ear, you certainly see lymphocyte, plasma cell, histiocyte-rich inflammation clustered under the epithelium. And you have these tiny little circular invaginated glands. These tiny little circular invaginated glands kind of recapitulate the cuboidal epithelium of the tympanic membrane. And this is an example of chronic otitis media with so-called glandular metaplasia. So these tiny little invaginations of cuboidal glands don't normally happen in the middle ear, but in this context, you see them with inflammation and you see them invaginated. This is perfect chronic otitis media. Okay, so we don't often see this, but if you ever were to get this on one of your slides, this is an example of prior or active chronic otitis, okay? And I know you guys have asked to see some rare things that we don't see very much. Well, here's chronic otitis media with glandular metaplasia and cholesteatoma, okay? All right, questions or we move on? All right, oh boy, we're really slow today. Okay, so next case of an ear. This is middle ear.
I can try this. I don't know if I got it right, but so at low power, well, you see this tissue, and from low power, you see kind of vessels that are dilated, and you see eosinophilic cells that are plump and have kind of larger nuclei, and they look like they're nested in a way, but also the cell borders are a little bit difficult to tell. So I think it gives sort of like a syncytial appearance. So it almost looked kind of at low power similar to the paraganglioma we saw, but at closer examination, the cells didn't resemble the ones that we saw earlier, and they didn't have the salt and pepper chromatin. So I went and looked up what I thought it could be. And the only thing that worked was a meningioma, which doesn't happen that often, but it is a location in the ear. Happens about 6% of meningiomas happen in the ear. And so then I also read that this would probably be more in line with a meningothelial meningioma, which is one of the subtypes. And another word for it is a syncytial meningioma because of the syncytial appearance of the cells.
Okay, and what immunostains are you going to do to differentiate your two tumors?
Well, EMA is very specific for meningioma. So I think I'd start with that.
Okay. EMA is negative.
Oh. S100. which
Okay,
would be positive for
S100
both.
shows a couple cells here and there, but it doesn't highlight the tumor cells.
So chromogranin, synaptophysin.
Okay,
and
right. So
GFAP.
if you, yes. So if Magna's first thought was this kind of looks like the other one we saw,
Yeah,
it does.
it
Okay.
is.
So here's synaptophysin.
Okay.
So
So maybe it is a paraganglioma.
maybe it is a paraganglioma. So paraganglioma is the most common tumor of the middle ear, all right? But in contrast to the other one, maybe the morphology is not so great because in the middle ear, these are tiny and when they take them out, they crush them to get them out. And so often you're just gonna see these crushed nests of cells, right? And so, but you picked up on that nested growth pattern, which is so true, right? This has those same nested growth patterns as the other beautiful paraganglioma in the neck, but some of the cytologic features are a little bit lacking. I would argue that the nuclei are quite finely stippled, maybe not as coarsely. Maybe it's not a coarse grind salt and pepper. Maybe it's on the fine grind setting.
Yeah,
right?
I was debating it.
But it doesn't have the nuclear inclusions like a meningioma. It has beautiful nested growth pattern. So always when you have a tumor of the middle ear, always think about paraganglioma first, because chances are that's going to be the most common thing. So this is a synaptophysin. These should be negative for keratin, negative for EMA. And because you're going to do your SDH, I wanted to show you what a retained succinate dehydrogenase looks like. So you can see how there's retention in the cytoplasm of the tumor cells. Now be mindful that these often have crush artifact. They often have fixation artifact. So you can see how the quality and quantity of the staining is varied over this tumor because potentially of those artifacts. But if in any area you can see diffuse, pretty strong staining of the tumor cells, that means that it's retained. So this would not be a patient that you would want to screen for the germline. So what is the other word for middle ear paraganglioma that you might see on your requisitions that you should not let confuse you? You can either write it or you can type it in the comment.
What is the question, Dr. Cipriani? What do we
What
call
is another name for a paraganglioma of the middle ear? So for in the paraganglioma of the neck, it was carotid body tumor. For paraganglioma of the ear, what is the clinical term that a lot of people use? Wait, no. What is an acoustic neuroma?
Schwannoma.
Right, acoustic
Yeah.
neuromas are schwannomas of the vestibular nerve. Yes. Glomus tympanicum.
Glomus tympanicum.
Yes, so yes, Mia, yes, Perry, yes, Heather. So glomus tympanicum is a jugulotympanic or middle ear paraganglioma. It is not a glomus tumor of the digits, right? It is not a perivascular myeloid tumor like we see in the soft tissue. It is a paraganglioma. Yes, glomus jugulare, exactly, would be the other quote unquote glomus for paraganglioma. So don't let the word glomus confuse you in the head and neck. Sometimes people call clinically paragangliomas glomus tympanicum, glomus jugulare, et cetera. So just people have gotten confused with that before. I just wanted to highlight that as a area to not mistake. Okay, so I'm just gonna move on to the next one. For expediency, so this is another middle ear tumor. Does it look different, the same? Don't know.
It's basaloid.
It does look basaloid. It is.
Yeah.
It has a very different
And you
appearance.
highlighted an area, like the origin, like it comes from the skin, I believe, like here, like, yeah.
How do you know whether this is skin or tympanic membrane?
It be tympanic membrane. It contains keratin, so it's keratinized. So maybe from the external eye of the external ear.
Yeah, I don't think it's coming from the, whatever the squamous lining is. I think it's kind of self-contained within it itself. I guess like I
Maybe
thought this was
below
like
the
a,
squamous lining, right?
yeah.
Really touching. Okay.
I don't
and
think it's
here's-
arising from
yeah.
it.
Okay. All right.
I mean, I thought this might be a middle ear adenoma just because of the like basaloid appearance of it. I don't see any myoepithelial cells. I think that's kind of key for that. And some of them I feel like are kind of trying to recapitulate glandular structures, but you know, I know they can grow in all sorts of manners and fashions, whether it's solid or trabecular. They're pretty common.
Right. So this arguably has also a somewhat nested growth pattern, but one might say that the nests are a little more variable in size. Some are large, some are small, maybe not quite as packeted as the paraganglioma. And as mentioned, some of them are almost trying to recapitulate glands, like little kind of tubular or nested or gland-like structures. Some of them have almost like a ribbanoid or ribbonish kind of growth pattern. Here's a little trying to recapitulate a gland with a little lumen in the center. So yes, these are much rarer than jugulotympanic paragangliomas, but in fact, your thought of a middle ear or written down ceruminous adenomas are good ones. So what?
Of course.
So there are middle ear adenomas that are kind of
So,
generic.
yeah,
There are middle ear adenomas that recapitulate the ceruminous glands or the wax glands of the ear. So, but the most important thing that you can do for either of those two adenomas is what stain?
Keratin?
Keratin, right? So this is an example of keratin in that tumor. I apologize that this larger fragment kind of got cut off, but you can see some keratin in this larger fragment, and you can in fact see some pretty extensive keratin in the fragments that we saw earlier that were underlying that other strip of squamous epithelium. So strong keratin staining should exclude a paraganglioma and should in fact point you more in the direction of a middle ear adenoma. So ceruminous adenomas tend to, those that recapitulate the wax glands, tend to have more of a discrete epithelial and myoepithelial bilayered phenotype, whereas in this case, sorry, my Zoom is getting all over the place. Whereas in this case, those duct-like structures that you saw, like you said, didn't really have an outer myoepithelial cell layer. So I would favor this to be more of a standard run-of-the-mill middle ear adenoma as opposed to a ceruminous adenoma, which would have the outer cells. Now, because middle ear adenomas, interestingly, can have neuroendocrine differentiation, this is an example of synaptophysin in this lesion. So just when you do a synaptophysin on something, don't think, oh, it's synaptopositive, it's a middle ear paraganglioma. Always also think about the keratin, because you can have co-expression of keratin and neuroendocrine markers in middle ear adenomas, but if you have keratin, it is an adenoma, all right? So I think we call this a middle ear, adenomatous tumor with neuroendocrine differentiation or something to that effect. But it's interesting how the immunoprofile of some of these middle ear tumors can be overlapping, and this particular one also happened to have neuroendocrine differentiation, even though it was gland forming and even though it was keratin positive. Okay. All right. So I'm sorry we went kind of slowly through the first two sections. We have the sinonasal cavity left. You tell me, it's 8:58. Do you want me to continue quickly? Do you want me to do another session?
Can we do another session where we can actually talk through it?
Yeah, I'm sure we can work one in. We haven't actually scheduled the next block yet. So if we want to add one on at the end of the ENT block, we have that flexibility.
Perfect. Awesome. So all of the remaining ones are sinonasal cavity. If any of you have any questions, let me know. If you want to take the quiz, also just let me know and I can assign you the quiz. Okay, got it, Faiza. Okay. Anybody else?